recording 3, 2, 1.
So just going to go ahead and start our symposium tonight. Good evening, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Abdulmajid Zubaidi. I'm a cardiologist and the president of the Emirate Cardiac Society. I would like to welcome you tonight to this session or symposium on atherothrombosis. We all know cardiovascular disease and atherothrombosis is the leading cause of death internationally and in the region. So part of the raising the awareness on atherothrombosis and the different options or treatment options to treat atherothrombosis, this educational series comes to you. 360-degree thrombosis. This is a wave of educational activity that is happening in collaboration with Emirate Cardiac Society and with the support from our colleagues from Bayer. The intention of this symposium is to raise the awareness. Tonight we have an excellent speakers, Dr. Firas Al-Aini and Dr. Abdullah Shihab. Both are going to give us more insights on the different options in managing atrial fibrillation and atrial fibrillation with coronary artery disease. The session is going to be 1 hour and a half. There will be 2 talks. And following that, we will have a time for Q&A, for question and answers. And so I would encourage you throughout the presentation to put your questions and answers through the platform, so we can trace it and ask the speakers. There's a CME hours for this event, so don't forget to log and your request for that activity, so the organizing company can communicate and get back to you on this part. So we'll just go ahead and start our session. Our first speaker, Professor Firas Al-Aini, consultant physician and Chief Medical Director of the Heart and Vascular Center at the American Hospital, Dubai, here in the United Arab Emirates. And he is going to talk to us about atrial fibrillation and diabetes case with focus in the renal preservation perspective. تفضل دكتور فراس.
Thank you, Dr. Abdulmajid, and it's an honor to be with you and Dr. Abdullah Shihab and with Bayer. I will just delve in straight into the presentation. Ziad, I'll just follow your lead. Do I share the desktop now?
Yes, please, Doctor, share your screen now.
Okay. Okay, so welcome everybody. Again, my name is Dr. Alani. I'm the chairman of the Heart and Vascular Center at the American Hospital of Dubai. We're going to be talking today mainly about atrial fibrillation, but not all atrial fibrillations, as we all know, come equal. And this is really specifically focusing on the combination of having AFib patients with diabetes and renal impairment. The first part of my talk will be talking into the prevalence of AFib and diabetes and what are the challenges that we see with these patients. Now, oops, excuse me. Now we all see Mr. Amin at least once or twice in our practice. He's a 76-year-old gentleman who has non-valvular AFib and diabetes and moderate renal impairment. Now he comes to you and tells you the usual story that my friend had a stroke and he's been taken care of by his caretaker. He has dialysis. He doesn't want to end up like him. So this is the kind of stuff that we face on daily basis. So diving into some of the data of prevalence. Now, we all know that diabetes and kidney disease coexist, and it's no surprise because it's about 1 in 3 patients of diabetes have kidney disease. Again, that's because diabetes is the major cause of kidney failure. Patients with chronic disease and diabetes, when you have both, now you're more likely to die of cardiovascular death than those without diabetes. So keep that in mind in our patient here who has both comorbidities. Talking about stroke, now we all know that AFib is bad. AFib is associated with 5-fold stroke increased risk. But also keep in mind that chronic kidney disease independently is associated with a 30 to 60% increase in stroke risk, and diabetes independently associated with a 2-fold increase in stroke risk. So these are 3 different players, 3 different offending factors on stroke, but imagine they would exist in fortunately, a lot of your patients that you see every day. So how do you manage these patients and what kind of choices you make in their management? Now, this interlink between diabetes and cardiovascular disease and renal failure doesn't stop at just stroke. It also extends into mortality. This is a cohort study of 15,000 plus patients from the third National Health and Nutrition Examination Survey. And you can see the mortality, whether it's cardiovascular or total mortality, over a span of 10 years. When you don't and these are AFib patients. So you can see when you don't have any of these 2 players, your risk of mortality is 7.7 versus 3.4. That risk increases to diabetes and increases with kidney disease. But notice how exponentially that increases when you have a combination of both. Now, whenever we choose an anticoagulation, we always have to pull up our balance and measure the safety versus efficacy. And there's no more important age group to use that balance than the elderly, because we know that bleeding complications increases with age. And I want to share with you, this is an interesting study that was done in France. It's a prospective registry called the SAFER AC. And what they looked at, basically, approximately 2,000 patients who received 1 year worth of date of rivaroxaban and vitamin K. And what you see here, what they looked at, the major bleedings, intracerebral bleeding, stroke, and mortality. And you can see within 1 year, a clear separation of the major bleeding and intracranial hemorrhage in favor of rivaroxaban. This is very powerful. This is the group of patients that we see. We don't see AFibs that are, I don't know about you guys, but most of our AFib patients, we see them in their mid-70s into the early 80s, and to a lesser portion in their 60s. This study highlights the balance, or addresses this point of safety versus efficacy balance in those patients, and it clearly shows the safety of rivaroxaban in the octogenarians and even nonagenarians, because this is the average mean is 86. So imagine there's probably a couple of patients in their 90s as well. So what are the biggest fears of patients with diabetes? Now, diabetes is almost like a time bomb. If you think about it, you control their heart, they get a stroke. You control the stroke, they get a PAD. Control their PAD, their kidneys fail. So it's almost an ongoing battle. You're watching these patients closely and handling them on a day-by-day basis. These patients have, as we all know, micro and macrovascular, and I would highlight the importance of macro and bring this to topic today where AFib comes into play. In AFib patients, about 7 in 10 patients die from cardiovascular disease. Higher likelihood of cardiovascular death, we're not talking about total mortality, increases with diabetes. It gives you a hazard ratio of 1.44. In Rocket AFib, we're all familiar with the study. This was the study that paved the road to rivaroxaban, and this is a subset of Rocket AFib patients who are diabetics. And what you can see here is that the primary efficacy, the major bleeding, the intracranial hemorrhage is consistent in the diabetic population with the general Rocket AFib population. Keep in mind that in this study, 40% of the population that were enrolled were diabetic. But I want to highlight your attention to the second row here, that and this was a post hoc analysis, when they went back and looked at the diabetic cohort in the Rocket AFib, and they addressed the question, what is the incidence of vascular death? And you can see a signal clearly towards favoring rivaroxaban. And this just highlights what we just talked about previously in the slide, is a macro complication or macrovascular complication of diabetics and cardiovascular death in specific. Another study that looked at this was more of a registry that looked at the efficacy, effectiveness, and safety of rivaroxaban versus warfarin in preventing not just cardiovascular event, but also limb ischemic events in diabetic patients. This is a study, again, retrospective in the US. I looked at patients who have non-valvular AFib and diabetes. And basically, they compared the effectiveness and safety of rivaroxaban versus warfarin in not just myocardial adverse cardiac events, but also major adverse cardiac events, but also major adverse limb events. So this pulls in the limb ischemia, which is a new player. And in summary, I don't want to indulge into the details of this slide, but you can see that the MACE events were clearly in favor in rivaroxaban, and also the incidence of MALE events, or the so-called MALE events, was clearly in favor of rivaroxaban in this cohort of closely 26 or 25,000 patients. How did they fare in safety? No difference, which we all see in, again, consistent with the Rocket AFib trial, that there was no signal towards a higher problem with safety or bleeding. So what are the biggest challenging in patients with AFib now renally? Now, this is a different spin to the topic, and I think it's very important to highlight how these patients in renal fare and the options that we have for treatment. In one study, it was a registry, it's called the Europe Registry, or EORP. They looked at 2,400 patients with AFib. Clearly, and this is not a surprise, that 2/3 of the patients who were in the study had renal impairment, and the stroke and mortality bleeding risk all increased with renal impairment. And we know this as a fact. But was also noted as an interesting signal that in those patients in that particular registry who were taking warfarin because of atrial fibrillation, they've noticed they have accelerated chronic kidney disease. And I want to highlight this very intriguing and interesting observation, because we're going to indulge into this in the next few slides. So basically, patients who received warfarin had noted to have accelerated deterioration. Their kidneys function just went south quicker than those who were not on it, warfarin. And I'm going to get to that point in a minute. Applying the renal patients in the Rocket AFib, just like we've seen in the diabetic, again, they took out only the renal players in the Rocket AFib, and they saw that their safety data is consistent with the remaining cohort of the Rocket AFib trial. Basically, what this slide says, that these patients, whether you look at it as a comprehensive cohort or only the renal players, the safety data was consistent. There's a signal of lower fatal bleed, of course, towards the rivaroxaban, but in general, most of the trend was equal with no statistical significance, which is what the non-inferiority primary endpoint of the study was looking at in terms of safety. Back to this Coumadin issue, which I thought personally is very intriguing, that another observation of a study that was noted, and what they looked at here is, again, the rate of deterioration of renal impairment. And you can see in the dotted line, these are the patients who actually were taking warfarin, and the straight line, the patients who were on no warfarin. And you can see that these patients actually had a rapid or more progressive deterioration in their renal function than those who were not. And they took this a little bit extra, and I want to share with you another study that was shared here on the right side of the slide. So this really generated a lot of hypotheses. How come these patients are getting worse or rapid deterioration in the kidney function with warfarin? And one thought was, could this have to do with their calcium metabolism? Now, the study on the right is actually addressing this. Here on the study on the right, they took patients and just took x-rays of their legs. Yes, x-rays of their legs. Basically what they're looking at, and those who are involved in interventional cardiology, and some of my colleagues, I know Dr. Abdul-Majid and Dr. Abdullah can attest to that, that you can see that sometimes we see this calcium in these legs, and you look at them, they look like lead pipes. Basically what they did is they quantified the amount of calcium in those patients who were on warfarin based on only x-rays. I know it's a pretty crude way of looking at it, but it actually panned out to be a pretty important signal. And they noticed that those patients with the darker bars, after 5 years, the amount of calcium, quantification of calcium by X-rays of the legs, was actually more pronounced with the warfarin group than they were with the non-warfarin group. Again, confirming the signal, or at least the correlation between renal deterioration and increase in calcium deposits, which could be related. And in this slide, I think it puts the basic science behind it. And in fact, those who are interested in cellular biology, you can kind of understand the slide. I'm not going to indulge too much to it, but clearly there's an inhibition by vitamin K antagonist, such as coumadin, to an enzyme that carboxylates, or carboxylase is the molecule MGP to carboxylate MGP, which in turn has a role of inhibition of calcium. They took this to clinical trials, and this is a famous Yao study. And what they found that in this study, that certainly there is this was a US retrospective analysis looking at, again, comparing NOACs to warfarin in 3 primary endpoints that are particularly related to kidney function. Number 1, 30% or more decline in GFR. Number 2, doubling of serum creatinine. Number 3, acute kidney injury and kidney failure. And I want to just highlight the bottom of the slide. You can see in the graph the 3 out of the 4 endpoints that were defined was clearly in favor of the NOACs. Here they included all NOACs, and in favor and not in favor of warfarin. So they was definitely a favoritism in terms of lesser a percentage of 30% or more decline in GFR, doubling of serum creatinine and acute kidney injury in the NOACs compared to the warfarin. Now, they then went ahead in the Yao study and divided those NOACs. Remember, there was 3 NOACs that were involved: apixaban, dabigatran, and rivaroxaban. And you can see here some differences. And I want you to focus at the bottom slide where rivaroxaban is. And you can see 3 out of the 4 endpoints that were defined as markers of kidney deterioration was statistically significant in favor of rivaroxaban compared to warfarin, while in the dabigatran, only 2 of them, but there was no signal towards doubling of serum creatinine that was statistically significant, but only 2 out of the 4. And in the apixaban, they were clearly a trend to better outcomes in the apixaban, but not statistically significant. So based on that study, the guidelines have changed, and then they made a soft recommendation by the American Heart Association, ACC, and the Heart Rhythm Society, saying that over time, NOACs, particularly dabigatran and rivaroxaban, may be associated with low risk of adverse renal outcomes than warfarin in atrial fibrillation patients. I'm sorry. I just want to make sure that I'm not crossing time. So another study, there was a Caliper study, basically looked at, now kind of similar to the Yao study, but they looked at mainly, remember in the Yao study, they took everybody and they looked at their kidney function. This study in particular looked at those who have existing stage 3 and stage 4 chronic kidney disease. And the primary endpoint was how fast did they progress to stage 5 or complete kidney failure requiring dialysis. Again, in patients who were on rivaroxaban only, so it was not like the Yao that included the other 2, versus warfarin. And clearly the dose obviously for rivaroxaban was 15 because of their chronic kidney disease stage 3, stage 4. And progression to kidney disease stage 5 or kidney failure clearly was less in the rivaroxaban arm and warfarin than compared to the warfarin. And it didn't matter if they had diabetes or not. Both cohorts benefited from lesser progression. So the signal is very strong. I mean, it's impeccable. I mean, this is clearly there is a preventative role in NOACs of renal impairment, and there's definitely some detailed information that favors some NOACs versus the other, and I'll let you make that decision. I want to end with maybe 2 slides on the 2020 updates of the European Society of Cardiology guidelines. We're still waiting on the US side to come up with the 2020, but I guess our colleagues in Europe are a little bit ahead on the Americans. These are some of the highlights. This part is more of a change of mindset because of atrial fibrillation continue to possess a significant burden. So now there's a change in the language and the change in focus. And from 2016, they had this 5-domain concept, but now they moved into the ABC concept, atrial fibrillation, better care. basically addresses the three components of atrial fibrillation. So basically, it just highlights that the 2020 guidelines is now really, really putting AFib under the microscope. Again, under the C component of the ABC, clearly decreasing the risk factors of comorbidities and cardiovascular. And I want to highlight the last point, that the bleeding risk with NOACs was similar in diabetic and non-diabetic. I showed you that. And also the patients, in all patients except for apixaban, there was a lower reduction in hemorrhagic complication among the diabetics compared to the non-diabetics. So just a small signal that the benefit of NOACs in reducing bleeding risk was across diabetics and non-diabetics, except there was a signal in apixaban that benefit was kind of ameliorated or weakened, and not as potent among diabetics. The guidelines teach us today, again, that class 1 indication, that there is definitely a preference over vitamin K's, NOACs over vitamin K's in the management of AFib. So the word preference was inserted in there. For stroke risk assessment, again, you have to use a CHAS-VAS score, which we use every day. I remember CHAS-VAS score as good as I remember my kids' names. The stroke, again, knowing that the 0 in men and the 1 in women are actually low risk, and you can actually walk away from putting them on antithrombotics. Keeping in mind that if it's 2 or more in men and 3 or more in women, you have to anticoagulate them. This is all class 1. So 2A becomes that middle of the way, where men is 1 and above or women 2 above. What do? There's a preference of oral anticoagulation in these patients, but you wouldn't be faulted if you go with antiplatelets. That's a 2A indication. And secondly, about the bleeding, again, the HAS-BLED score has to be part of your daily or regular assessment. Remember that patients with HAS-BLED score above 3 are considered a high risk for bleeding, and these patients have to have assessed periodically intervals. These HAS-BLED and CHAD scores are not a name you're given to when you're born. They actually change as your patients grow and get more morbidities and more drugs on board. And the most important thing is that this is a class 3 indication. And I see this in some of my practice. People say, okay, the patient is a high bleed risk, I'm not going to anticoagulate them. That's kind of a very debatable thing. I mean, you can assess their full risk or something, but certainly in the guidelines, the estimated bleeding risk in the absence of absolute contraindication of oral anticoagulation should not itself be the guide in treatment of oral anticoagulation. So in summary, these are the keys that we take away from today: prevention of stroke, preservation of renal function, very, very important, mitigation of bleeding risk, preventing cardiovascular death, and protecting following stent placement. I'll leave that up to my colleague, Dr. Abdullah, who will be talking about that, and optimizing the dose and supporting adherence. I want to summarize by saying renal impairment is a common feature in patients with AFib, 2/3, and it is increasing with age. Novel oral anticoagulant dose adjustments are recommended in patients with moderate impairment, and this is across all the NOACs. A specific renal NOAC dose was prospectively tested in the Rocket AFib. This is something I didn't highlight, but in Rocket AFib, this was predefined in the trial, and actually was a larger portion of the population of the trial that actually were tested in that dose. So I think this is really kudos to the Rocket AFib investigators. Adequate preservation of renal function is vital. Studies have suggested that vitamin K antagonist exposure has been associated with worsening renal function. Again, the hypothesis of calcium metabolism theory. And studies have also suggested that better preservation of renal function has been observed with rivaroxaban as well as with dabigatran compared with warfarin, and that's from the YAO study. Hence, the guidelines put it as a preference as 2 options for renal impairment patients with AFib. Thank you very much for attention, and I will pass on the podium to my colleagues, Dr. Abdul Majid and Dr. Abdullah.
Great.
Thanks, Dr. Faras, again for this excellent and elegant talk. We'll move ahead to our next speaker, Dr. Abdullah. Dr. Abdullah Shihab. Dr. Abdullah is Professor of Cardiovascular Medicine and Editor-in-Chief of New Emirate Medical Journal, and he's talking about the management of coronary disease patients. Please, Dr. Abdullah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Al-Majid. Dr. Firas, I'd like to really thank Emirate Cardiac Society, led by my colleague and friend, Dr. Al-Majid, with great activities, really of great practical, I think, to all of us. The topic you heard already from Dr. Firas was excellent. I think very practical, case-based. So I'm going to do in a few minutes is share with you, my thoughts and management of coronary artery disease, especially focusing on antithrombotic. So we know this is my disclosure of Norian fire in the past. So since we are living this, we have to remind us, to be careful and not to, be distance, all that taken into consideration. The cardiovascular disease, as Dr. Al-Majid said, is a leading cause of death. And we did really published recently, I think in just 2 months ago, looking at the 200 subjects with who are at risk of having cardiovascular disease. And our prevalence of cardiovascular disease in this part of the world, Middle East, compared to the world, we are 2-fold higher. So in the world is 4%. We are 9.2. So that's really tell us that, we have maybe the risk factors we have at higher magnitude. Maybe it's coming at early stage. And we look at the risk factors, which is leading in our part of the world, is led first by dyslipidemia, then comes hypertension, then comes the diabetes and smoking, of course. So atherosclerosis and thrombosis. And this is the 2020 CCS, which is chronic coronary syndrome, they call it. So it's not anymore called stable, because you can see if you are here, it's just, if we are not controlling the risk factors effectively, so we will have lots of events, either that could be presenting as a new heart failure, or could be a new acute coronary syndrome, and so on. If we control the risk factors, then among them, of course, the one which I mentioned, we're able to reduce that. But of course, the 2025, they say they want to reduce the cardiovascular disease by 25%. So we need lots of effort together. So this is the thing we need to do, focus antithrombotic therapy, which I'm going to focus on this today with the case, and not to forget always lipid control, blood pressure, glycemic control, of course, and lifestyle, very important. Let me go through this short case together. 66-year-old female, obese, so that's risk factor. Smoker, another one. Being a female and smoking is bad. Medication for DLP, type 2 diabetes, patient known chronic renal failure, hypertensive, coronary artery disease, 2 vessels, and TIA. She's concerned about future cardiovascular events. She comes to you, doctor, no, I am, maybe I'm stable, have no symptoms, but what's going to happen to me? You already seen what I showed you, and how we're going to protect her from this patient for cardiovascular events. There are many things we can do. You already mentioned to you, she got lots of risk factors there, which is, comes together. They cluster together, the hypertension, diabetes, dyslipidemia, obesity, having coronary artery disease already, so polyvascular problem there. So this patient already had problem in the past, and she is here, and she thinks about future. This is the future if we are not controlling her. And the guideline says what to do. So I will not go through the COMPASS. COMPASS was one of the, I think, major landmark randomized clinical trial, more than 27,000 patients randomized to aspirin plus vascular dose of rivaroxaban, which is 2.5 twice a day, plus rivaroxaban 5 milligram twice a day. And then the outcome, very clear here, is that the rivaroxaban vascular dose, 2.5, plus aspirin, compared to aspirin, is outstanding in terms of primary prevention MACE. And that's, we can see in terms of vascular protection, cardiovascular protection, highly significant relative risk reduction. Of course, that comes to the guidelines. The guidelines here says 2A and evidence level A. That means come from randomized clinical trial. 2A, that means it's should be, when the patients for secondary prevention long-term is to be somebody like polyvascular disease, having 2 vessels, having coronaries with peripheral, or having coronaries with the diabetes or renal or heart failure, then these, and with a low risk of bleeding, to be started on this combination, which is 2.5 twice a day plus aspirin. And if they are a bit of moderate risk, which is here, tells you if any of these, then the patient should be started on this. Again, remember 2B, that means not majority, but it's reasonable to do it. So basically, if you look here, I already showed you, so how much we can, that patient is concerned now. I had in the past cardiac event, I had TIA, I already have all the risk factors, how much protection I will get, and you can see from the compass, and this patient, you see, all the things in her mind will be reduced if she is going to start on this medication, which is 2.5 rivaroxaban twice a day plus aspirin. And then the concern about the bleeding, always you hear that bleeding, bleeding, bleeding. And this, there's no major difference in terms of fatal bleeding, but majority comes from GI. And really, if you look at the experts' opinion, and this in GI or urinary bleeding, it's those who are revealing their risk of cancer rather than just, so it could be kind of early recognition of cancer in these patients rather than just risk of, just major bleeding. And it's not just for, certain time, it's continuous. So ischemia, as you can see, it's, is reduced, you can steadily, you can see here, compared to the bleeding, which is kind of remain relatively low, which is good news. And in addition to that, patients, at this age, worried about death. We're all worried about death. We don't want to die prematurely. And this is, again, protection, kind of give you protection, of course, from mortality. Again, that's rarely to see nowadays, a medication which give you, cardiovascular protection, stroke protection, and in addition to that, mortality protection. And the more, this patient actually very high risk. You already seen that. Many risk factors, already had event. So basically fulfill all these criteria here. And so the more of you have, more of this patient got, the more will get the benefit of protection. So the number, normally we talk about that number need to treat. So you see the lower the number, the better. So patient with 2 vascular bed, that means coronaries, peripheral, coronaries, carotid, or some, now expert says coronary with the renal, considered as another vascular, which is, I think most of our patients got that. So you can see you need to only treat 17 to protect all that benefit, the mortality, the cardiovascular, the stroke, the MI. So it's great news for I think for our patients in this part of the world. And this, is, as I said, is this benefit continuous over time. It's not a first year, second year, ongoing, because that's the ischemia. Ischemia is continuous problem. And the more risk, it's another way to look at it, the more risk we have, the better the benefit. It's another way to look at it. So many ways I put it, so we can people absorb it. Okay, so what we learn from the compass, which I already said to you, is one of the largest. I think when first time I heard about compass, I said, now I'm struggling with keeping patient on aspirin. Now that, and then we had problem with clopidogrel. Then I said, okay, when is time to stop this clopidogrel? But when I heard and I saw the result of this, especially this study, which is stop prematurely. You see the expert and the safety, they don't stop a trial prematurely unless 2 reasons, okay? Either is causing problem, major problem, or causing great benefit, they might deprive others from it. So stop prematurely because the benefit was outstanding. And you can see at all levels. So that was the thing, And this patient had multiple risk factors, I already mentioned to you. And not, maybe this patient not in target lipids, maybe not target hypertension, maybe not target the diabetes. But if you compare this patient to the randomized clinical trial patients, all of them had almost into target. Despite of that, being on target blood pressure, lipids, diabetes, and other risk factors, despite of that, they get the benefit. So imagine. So So here's the question. So, I mean, does it relate to the risk factors? Of course, the more risk factors, you have benefit, but it is the benefit of it is there regardless. And you can see here, it's not being affected by the, risk factors. So when the odors have been controlled, still you get the benefit from these medications. So put this into the perspective. Now we use many things as a secondary prevention. Yes. So when patient comes to us, we try, keep them on ACE inhibitors, on aspirin, on, statin, on blood pressure medication. How much benefit we get compare, you can see here. You can see all that, even the PCSK9. Compared to the Compass, where when we reverse 1 plus aspirin, even you can get, look, how much benefit, 46, 14, 42, 18, 24, compared to others, much, much better. So we in American Society and my colleague, Dr. Al-Majid, were kind of thought about how we can come with something simpler, something easier for people to use, because the guidelines I already showed you, it's just a bit difficult. So somewhere to start, somewhere to get your experience. So any patients, we think, of chronic artery disease, okay, and with a low bleeding risk, 2 vascular bed here. I mean, I say to the GPs, or to our colleagues, somebody with chronic artery disease, 1 vessel, okay, and got a peripheral vascular disease, or carotid, or renal, so that called up more than 2 vascular beds. Okay, then a history of that prevalent is diabetes and history of heart failure or renal problem. This patient definitely should be on this regimen. So this is, we put it like this for our colleague, and it's going to be soon, inshallah, published and available to everyone. So I hope through this short journey that focusing, on factors, not to forget, optimize that, and it's in our hand, and we can do it tailored to our patient, and not to forget the benefit of this medication, which is available now in the country. And thank you very much.
Thanks, Dr. Abdullah. This is great. And again, thanks, Dr. Frost. I think we have plenty of time for the discussion. I would go ahead and get a question. I would like to remind the audience that and participants to share their questions through the Q&A place on the platform. So Dr. Abdullah, if I would like to ask you now, you having, we get the patients, majority of our patients in the hospitals are acute coronary syndrome patients. Either it's an acute STEMI, or it's an acute or an STEMI, unstable angina. These patients, they come in, they get cath. The majority of them, they will end having a stent. And we start them on dual antiplatelet therapy from the day they get admitted. And most of them, they end on dual antiplatelet therapy. And when we say dual antiplatelet therapy, we mean aspirin and ADP inhibitor, or like clopidogrel or ticagrelor in UAE. We don't have prasugrel. So it's either aspirin ticagrelor or aspirin clopidogrel. When it comes to thrombin or like a rivaroxaban, if you have a patient on aspirin, on dual antiplatelet therapy, when would you consider switching him to, to aspirin and say a rivaroxaban? 6 months, at 1 year? What kind of factors are you going to consider when you're switching these patients? And would you consider continuing the dual antiplatelet therapy for a longer period? We say for those who had stents, 1 year or 12 months is the minimum period of time that the patient should be on a dual antiplatelet therapy, at least till now, based on the guidelines. We know there's a lot of trials that are coming for a shorter adapt, But for a longer DAPT based on also another trials, like from the start of the Charisma all the way to the DAPT trials and other trials, when would you go with the long-term DAPT? When would you go or switch to an antiplatelet and a rivaroxaban as an example? Long question, but I'm trying just to make it practical to our colleague and to the audience.
I mean, excellent question, Dr. Al-Majid. And we always debate about this, when to stop really the dual antiplatelets. Again, this is really, as you said, tailored to the patient. But if you want to give a general message, I think, as you said, those with a very high risk of ischemia and low risk of bleeding, then we continue dual antiplatelets, at least 1 year, even sometimes beyond, depends on how complex, was the lesion we tackled. Those with, of course, with a high risk of bleeding, we try to make it shorter and try to go with monotherapy, even with the, with the evidence now we have. Now, what about the comp? How to put the comp? I'm sure, you were with us in this consensus. We came with a simple, pathway to, we said, give it time, give it when you feel comfortable. Get experience with this vascular protection. I don't want to really to give focus on something, we are not yet hesitant when to stop the dual antiplatelet. But I think after 1 year, those who fulfill the criteria, Doctor, polyvascular, patient already got perivascular disease, and I think got more than 2 vessels disease, which is maybe not a stent. I'm talking about maybe one stented, but the other is not as stented. It's just remain for the medical treatment. And the patient is diabetic, patient is with renal. I think this the patient should be really considered because you want more protection. More protection.
The COMPASS trial, how would you apply it to that patient?
This is what I'm saying. Trying to say after 1 year, then, and here if I'm thinking to stop the antiplatelets, which is normally the clopidogrel or ticagrelol, then here the time I want to protect this patient from future events, which I mentioned many of them: mortality, cardiac event, stroke, even the stroke. So here, I think the patients and fulfill the criteria. Already got polyvascular disease, already got a renal problem, already got diabetes. So this is the patient I will definitely consider that.
Excellent, Dr. Firas. The adherence. I liked one of the slides you talked about the adherence, and I remember with the vitamin K antagonist or with warfarin. The patient comes in, we do an INR, and then they're therapeutic. A good number of patients, they're not in the therapeutic window, but at least that tells me something about the adherence and that the patient is taking the medicine. Maybe not, maybe sometimes the patient is just resistant or some interaction happening in the vitamin K antagonist. But with NOACs, how would you ensure adherence, especially in a high-risk thrombotic patients, so those who are at high risk of thrombosis? And how would you address the adherence? We have a challenge in our region when it comes to compliance with medicine. We see stent thrombosis with antiplatelet, but in AFib, do you have any special advice?
Oh, thank you. Great question, Dr. Hamid. I think it's an international problem. I don't think it's just a regional problem. And across the globe, the warfarin adherence is approximately 50%, and adherence to NOACs is really not by much more than that, maybe 70%. I remember one of the slides that I've looked at. I think adherence really goes down to awareness and patient education. At the end of the day, patients will do what they want to do. I think a few things come to mind in terms of trying to emphasize the adherence. Is one, as just a simple concept, a 2-pill regimen and a 1-pill regimen, and maybe this is more of a favoritism to rivaroxaban, but in general, patients will, if they're not going to adhere, they're probably not going to adhere to missing a pill here and there. But if they miss 1 pill and they have Usually the one pill is easier to remember than the two pill. And I think that would be one way of looking at it. But at the end of the day, it's a big issue, and patients will just either take it or just have to deal with side effects. Or sometimes the worst part is actually they tell you take it and they adjust the dose. And I don't know how to address that one. They will just say, I've been taking this pill, but I decided to take 10 milligrams of the rivaroxaban instead of 20. So it's an active challenge.
Talking about the dosage, you talk about the renal, and so when do you consider adjusting the dose?
So in general, if for the renal dose, it's usually if it's 15, between 15 and 39 is when you have to minimize the dose of the or just the dose of the NOACs in general, and specifically for rivaroxaban, it's if their GFR is above 50, the dose is 20 milligram per kg. If the dose is, if their renal clearance or the GFR is between 15 and 49, I apologize, I said 39, 15 and 49, is the dose is 15. And there's really no strong data yet that we know of. There's some signal about safety in using rivaroxaban and apixaban in the dialysis patients and the low GFR. But these are still haven't made it to a strong level of guidelines in terms of class 1 indication.
Okay, great. Just Dr. Abdullah, I know that we had a statement and we talked about putting some sort of a local guidelines into the anticoagulation of patients with specifically with with coronary artery disease and atrial fibrillation. And as you stated, the document is coming. But I had a question that comes from one of our colleagues here, and it says, is rivaroxaban in the guidelines of the European Society of Cardiology? And I think I saw some of the slides. Can you just highlight it again, or highlight the recommendations on that section of the guideline?
It is in the guideline 2019, Dr. Majid, as you said. It's saying adding a second antithrombotic drug to aspirin for long-term secondary prevention should be considered. That's 2A, level of evidence A. Those with a high risk of ischemia and low risk of bleeding. That's 2A. If it's lower than that, what I mean by high risk of ischemia here, the patients who got coronary artery disease and diabetes or recurrent MI or PAD or CKD, one of these.
Okay, I think that's very clear. Also, a question about the FDA, and I know that this is an FDA-approved, molecule or drug. Another point that I thought is important is, after the COMPASS, I know the European Society of Cardiology guidelines were, were updated and based on the results of the COMPASS trial. But in the American College of Cardiology guidelines, I don't know, what's your thoughts? Is there any, what kind of levels were they given, or was the guidelines there updated on according to the COMPASS trial, or is it in the process?
To be honest with you, I cannot. I don't think I came across it, Dr. Bajid. The one is obvious is that.
But clearly, I mean, we have, the European Society of Cardiology guidelines is very clear. It gave it a class 2A, which means that the majority of experts would, would give it to a high risk patient, and those especially with the low bleeding risk. The safety, let's, we've been talking a lot about the benefit of, and when would you give it, and the comparison when it comes to, dual antiplatelet therapy versus switching. But the question on the COMPASS trial was aspirin and rivaroxaban. Can you apply that instead of aspirin? You apply it to clopidogrel. So patients who cannot handle aspirin, and we sometimes we move patients to a single antiplatelet therapy, which is clopidogrel. Or would you use those results? I know there's no data, but if I am to use a clopidogrel, how would you, would you be keen to apply the same results on that recommendations in the guidelines? I mean, if we go back in the history of aspirin and in comparison to clopidogrel in Capri, Capri showed a clopidogrel safety more than aspirin. So I know there's no data, but I would say it can be considered, but I don't know what's your thoughts, both, Dr. Firas and Dr. Abdullah.
And this is the territory where we have no randomized clinical trial, but again, it depends on the interpretation of our, of the observation and our experience. But I think, the aspirin benefit is, some kind of, established as a prevention even from GI cancer. But I don't think the clopidogrel. That's why we have GI bleeding, and they said they compared it to patient who had rivaroxaban, for example, and they had more bleeding with aspirin, and they say it's blame coming from aspirin, but actually coming not from aspirin, not from even from rivaroxaban. It's coming from revealing those people at risk of having GI. Clopidogrel, some study shows more bleeding. Some study shows, that's why these are more potent, doctor, as you know, more potent, more bleeding compared to aspirin. But I mean, since I don't have a data, it's kind of just just guessing. Well, I don't know. I will not start patient if not able to tolerate aspirin. Then I will not go with this regimen. I will go with another regimen which is available in the guidelines, is to go with the dual antiplatelets, and maybe that will protect. Maybe here I think about more potent antiplatelets, like as you said, ticagrelor, but not. I will not go with the regimen with something not being studied.
Okay.
Yeah, I have to. I agree with Abdullah and on this one. I have to say that I think we need to look at this as your earlier question pointed out, and Dr. Abdullah Shahab alluded it nicely. It's all about the timing of where you introduce that second pathway. Now, we all agree that the guidelines say if it's an ACS patients, you continue the DAP therapy for 1 year. If it's a non-ACS patients, you continue for 6 months, maybe 3 months. So let's just make sure that we know that this is out there, and this is where the minimum duration of DAP therapy is required. This is not where the COMPASS trial came into. COMPASS trial came into after they finished that 1 year, and after they finished that 6 months. Is there a benefit of adding that second pathway? And it showed clearly there is, and it's pretty strong data and highly described and nicely described elegantly by Dr. Abdullah. So now the question here is, back to your question, Dr. Abdul Majid, excellent point is, well, where does the Plavix fall into? I think the data is also going to be, what is the question before that is, what is the data on chronic Plavix therapy? So we're not talking now 6 months and 1 year. We're talking about after 6 months and after 1 year. Yes, there is the Charisma trials, and there is the other trial that I'm blanking on the name on, but basically advances Plavix or Berlanta for that matter beyond that 6 months and beyond that 2 year. Now that becomes more of an issue of discussion, but of a smaller group of people. But the majority of patients who have a STEMI or have an ACS that continue for 1 year, or basically they continue for 6 months, they're going to end up on aspirin. And I think if we apply COMPASS, we apply it to those patients. So Is there a role for applying this on the Plavix beyond the 1 year or beyond the 6 months? I don't know. And I think the data is that the guidelines are not addressing this. We don't have data about it, but I think the concept is there. Inhibiting antiplatelets by one drug needs another inhibition on another drug, which is rivaroxaban here. And I think we will have to wait to see if there is. Now, on the other hand, I will just end by saying, what is the safety? And I think one of the questions was attached of adding rivaroxaban to Plavix. That's been demonstrated. We use this all the time in AFib patients who have existing CAD. So that's not an issue. We just need that efficacy point in a evidence base to support the addition of rivaroxaban to Plavix beyond the 6 months in non-ACS patient and after a year in ACS patients.
I think you referred to Atlas maybe, because we have not.
Thank you. Yes.
I think that's great. That's a great insight. I got a few questions here, but before I move forward, let's stay away about the risk. Go back to the risk assessment of the patient. And I don't know if there's a data that talks about the gap where what is the percentage of patients that you think should be on anticoagulation or on direct thrombin inhibitors, and they're not, say, AFib patients, Dr. Firas. I know we're not optimal. We don't assess our patients appropriately. So sometimes you have patients with AFib, they're not on anticoagulation, and the reason is either the CHA2DS2-VASc assessment of the risk of the thrombotic risk is not appropriately assessed, or the bleeding risk is overestimated. So underestimation of the thrombotic risk and overestimating the bleeding risk, and the patients are denied the treatment. So do we have an idea as to, how many patients, or what is the percentage of patients that are denied, and what kind of, of interaction can we, or action can we do to help addressing this issue?
I think a great question. And I think the 2020 ACS guidelines address this very clearly, because it is, again, it's a global problem, not just a local regional problem. And I think physicians tend to be a little shy because of maybe personal or preference to say, I don't want to deal, or maybe the medical legal aspect where, with that, we don't have that as robust as we have it in the Western world, where I used to practice. We used to always prescribe medicine and look behind our shoulders if there's somebody from the law firm looking at us. But I think it's important because we have to stick to the guidelines. It's either, you believe in the CHA2DS2-VASc and the Hasbled, or you don't. And it's really, to me, it's like a religion, for lack of a better example. I mean, these patients stroke if they have a high risk for CHA2DS2-VASc, 2 or more for men and 3 or more for women, and then 1 or more for men and 2 or more for women in a 2A indication. These patients need to be anticoagulated. Well, what is the risk of bleeding? Then you have the Hasbled score. And I think in today's world, an informed patient decision is crucial. And I think we all should sit our patients in and say, look, this is the medicine. These are your risk of stroke. We can say it with all the data we have. Your CHA2DS2-VASc score of 2 gives you the 1.7 risk of annual risk. If it's 3, it gives you 1.8. If it's, and we have that number. On the other hand, this is your bleeding risk, and have them make that shared decision. But for us to make that decision on their behalf, I think we could be really depriving them, like you said, of a proper therapy. Now, there are ones who are absolute contraindications. Maybe those are the ones we could consider other modalities, such as left atrial appendage closures. But the idea here is to identify those high risk, put it on the table, share the patient with their decision, and give them the medicine. I think that's what they need, because a stroke is not fun, and the bleeding is not fun. But I think it's all what we do every day in our practice is benefit versus risk.
I like your, your way of, the message you're sending, which is a dynamic risk assessment. So, and when I see patients with AFib, I like to see on the visits kind of a regular assessment of those risk scores for atrial fibrillation. Unfortunately, sometimes you don't see it on the follow-up. So sometimes the patient is on it, but the bleeding risk goes up or it goes down, and or the other the thrombotic risk is going up or down. And unfortunately, it gets assessed sometimes once, and people kind of forget about it. So I think I don't know if you would share with me the same recommendation, which is I would recommend that our colleagues document regularly when they see this patient in their progress, in their notes, in their visits, the patient's risks routinely, because that helps you adjust your decisions also. A question on patients who comes to you with acute coronary syndrome while they're they're on a NOAC. So patient on a NOAC, especially say coming with acute coronary syndrome, let's take the scenario of a STEMI. How would you manage? This comes from one of our colleagues and the participants. And so how would you handle that? Either Dr. Abdullah or Dr. Firas, anyone can take that.
I think being a radialist, Dr. Najid, and now we are almost all of us practicing that. And that should be the for anybody with STEMI. Imagine if the patient already on NOACs or high risk of bleeding. I think that's another one way of keep things safe. We don't reverse, although it's available. Some of the NOACs available, the antidote. We are not reversing unless really there's a major fatal bleeding. But most of the STEMI, we just go straight forward with radial, and we just give heparin as we used to give. That's what I do.
Yeah,
and of course
I do the same. Yeah, it's really you have to take what's important on the table now. They come in with STEMI, the radial cutoffs for even for warfarin and INRs have significantly been a non-issue. So we learned this from the INR era, and we learned it in NOACs. Being a radial, you just go in and you take care of the problem. Now, what do you do after? I think the data is pretty strong for triple therapy. I would not recommend any of the second generation 2B3A inhibitors. I'm not sorry, 2B3, P2Y12 inhibitors in the context of a triple therapy. So what do I mean by that? Now, if they're going to be on NOACs, unfortunately, the Berlenta and the Prasugrel, which I just heard that's not available, is the safety of data on that combination is limited. There is some small data, but these are the patients who probably will be on triple therapy post, and then at 1 month you can stop the aspirin and keep the Plavix and the NOAC.
Yeah, I agree with you. I slightly maybe differ in that way. I mean, most of my patients which have with atrial fibrillation, I discharge them on either must be Plavix and NOACs. But I stop the aspirin most of the patients when on discharge. And this patient really of high risk of multi-vessel disease and stented, and there is an opinion coming from experts says because of the risk of coronaries more than the stroke at that stage, you even might able go with the dual antiplatelets and even stop the anticoagulation. But this is coming, not yet.
Great. Let's say, one of the questions here that I don't think it's, important to address this, and because the Hungary law is not available, and I think, in the country, and I don't know if any of you is, is aware that it's around. I know I haven't used it, and I don't think it is available. But the question is, what is the opinion if a patient is on a NOAC, would you give a cangrelor when they come in? And I think that applies to the same thing as you talked about earlier. I would not, I would not use it. Safety, I mean, of the NOACs, if you want to compare, I know there's a good good papers out there that compare randomized controlled trials, the different RCTs when it comes to their safety, to the NOAC safety. So there's a comparison across the trials, and sometimes it's, we have to take that in caution. But can you highlight some of the data around the safety and in terms of preferences when it comes to selecting the anti-thrombotic regimen?
For me, it's fine, because we're speaking about coronary artery disease. There's no other anticoagulations. It's the only one. So maybe Dr. Ross, you have a challenge now.
Sure. No, I think it's a great question. I mean, we all know that we do not have any head-to-head comparison in terms of safety. So a lot of the safety data is really extrapolated from different, from the landmark trials of the 4 NOACs, the Rocket, Arstol, and Engage and Rely. And honestly speaking, I mean, all these NOACs are novel, and compared to warfarin, they have proven their safety. Now, there's some nuances as to the safety aspect when it comes to bleeding in terms of how the trial design was. I will say they all went in with a non-inferiority design, meaning it's as good, is it as good as warfarin or not? And then in a post hoc analysis, some of the studies, well, most of them, all of them met the non-inferiority, but some of them went back and said, well, hey, we also met the superiority, which is not, we're just as good, but we're actually better. And I think that has to be taken with a grain of salt. And I think that's, it's important to look at it, but it is, at the end of the day, it's a post hoc analysis, and it's not a predefined endpoint. Although I think in the Rocket was a predefined endpoint. But that's something we could always use, and it's if I recall that there's some superiority on the safety data on rivaroxaban in terms of intracranial bleeding against warfarin. But again, that's not the primary endpoint, and that has to be taken with some precautions.
Great. I think we have a great discussion, and we addressed all the points that is brought up by by our colleagues who attended. We have a good number of attendees, and I see online at least there's 170 attendees there, and I think it's a great discussion. There's a lot of stuff to talk about, and the right combination of antiplatelet and antithrombotic for patients with coronary heart disease only, or coronary heart disease with AFib. Sometimes it is a challenge, and with a lot of data, it makes it more challenging. But I think it tells us that we should be able, as a clinician, to customize our decisions according to to the different risks, the thrombotic risk on one side and the bleeding risk. So those different options of different molecules that is out there, whether it's antiplatelets, antithrombotics, is there to help us making the right choice for the right patient. Before we we move ahead and close, I would like to remind our colleagues who are participating in this symposium to apply for their CME. I would like to thank them for for their participation, and of course I would like to thank Dr. Firas and Dr. Abdullah for this great contribution and the excellent talks and the excellent discussion. I enjoyed the session with you guys, and would like to thank our colleagues from Bayer for their support for this educational session. Great, and we'll see you in a future event, inshallah.
Thank you very much.
All right, thank you, Dr. Abdul Majid and Dr. Abdullah for the opportunity. And I also want to put a shout out to the Emirates Cardiac Society for the great work that you guys have done. I've attended the meeting. That's all, again, into the efforts to Dr. Abdul Majid and Dr. Abdullah and your teams. And it's really an honor to be with you guys. Thank you very much.
Thank you.
Pleasure to be with you.
Thank you, Abdullah. Thanks, everyone.